You're tuning in to the O&P Check-in, an SPS podcast. I'm Brendan Erickson, a regional sales manager at SPS. This show brings you the latest happenings in the O&P industry. We're unpacking trends and news from this tight-knit orthotics and prosthetics community. Co-hosting with me today is SPS Sales Account Manager and Certified Prosthetist Orthotist, Pierre Masson. Welcome, Pierre.
Glad to be here. Thanks, Brendan.
Yeah, buddy, let's do it. Let's get started.
SpriStep, off-the-shelf ankle-foot orthosis, is an elegant, durable, and effective AFO developed with a precise composite materials makeup. The posterior spiral strut is uniquely positioned to amplify energy return and fits easily to most shoes. Search SpriStep AFOs at spsco.com or follow the link in our show notes to learn more.
We've added 12 new products to the SPS Rewards program from College Park, Proteor, Willowwood, Oser, Autobach, Nabtesco, and TrueLife. Follow the link in our show notes to check out the latest items and browse the full SPS Rewards catalog. Hello, listeners. I'm thrilled to welcome today's guest, Jim Reichmann. Jim has a Master of Public Health from Georgia State University and has published on amputee post-operative care in the Journal of Vascular Nursing, PM&R Journal, and current physical medicine and rehabilitation reports. Jim has also served on a technical expert panel for the Agency for Healthcare Research and Quality, worked with the Food and Drug Administration to discontinue the use of a dangerous drug in pregnancy, and contributed to various evidence-based guidelines for payers. Jim is with us today to discuss the evidence surrounding amputee post-operative care. Welcome, Jim.
Yeah, thank you, Brendan. I appreciate the introduction, and thank you for having me.
Absolutely. So to start, can you tell our audience the essential components for an effective post-op program for those that have experienced a loss of limb?
I'd be happy to, and I think that's a great place to start. When I talk to audiences, and I speak all over the country about post-operative care of the transtibial amputee, but amputees in general, major limb amputations, I talk about healing the head, the heart, and the residual limb. And I think you have to get all three of those components for a complete healing process for the amputee. Four things affect the outcome of amputees. Number one is surgical technique. Secondly is post-operative dressing and support system. Thirdly, site of discharge. And fourth is intensity and duration of physical therapy. The prosthetist has a tremendous influence over the dressing choice and the provision of peer support, two very important components in post-operative healing.
Jim, for listeners who might not be familiar with a removable rigid dressing or also an RRD, what does your research show are the benefits of doing that?
Well, Pierre, that's a great question. There's four available dressing choices post-operatively for the transtibial amputee. There's the soft dressing, and which is normally with a neomobilizer, hard cast, weight-bearing IPOP, or immediate post-operative prosthesis, and removable rigid dressing. And 85% of the patients receive a soft dressing and a neomobilizer. 14% of patients receive a removable rigid dressing. And those are things such as your listeners may know, the FlowTech device, Limb Guard, AmpuShield, or even individually fabricated devices. But basically, it's a hard surface that provides the same benefits as a hard cast, a rigid cast. However, it can be easily donned and doffed to frequently inspect the residual limb and the surgical wound. I'm really device agnostic, so I don't really care what removable rigid dressing people use, but the discussion should be around elastic bandages and neomobilizers, which is about 85% of the market, compared to removable rigid dressings, which is the second largest market share, which is about 14 or 15% of the available dressings. Now, I did a review in 2018 in PM&R Journal, which Brendan mentioned at the beginning of our podcast, on removable rigid dressings. And it was an extensive review. And it showed faster healing, reduced edema. The RRDs assisted in limb contouring. prevented knee flexion contractures, and protected, and this is very important, protected the residual limb from damage due to falls. In that review, there were 16 studies, and that was all of the evidence on removal of rigid dressings. There now are 20 studies. There have been 4 studies since the year 2020 that have been completed, 1 randomized control trial, 1 systematic review, and 2 case series. And all of those showed benefit to an RRD versus an elastic bandage. It begs the question of why don't people use this if the evidence is so overwhelming? And we'll get more into that as we get into our podcast. But when I surveyed users of removable rigid dressings, when I asked them why they used them, they universally came up with the exact same initial response. And that was to protect the residual limb from falls because of this high fall rate that they had observed in this population. So it was really fascinating. And one important article in the evidence that I'd like to point out to your readers that is in support of RRDs is the Dewari study, which was done in Washington University at St. Louis. And the importance of this study for your listeners is that it was the only study that looked at and demonstrated that if an RRD was used, more patients were fitted for a definitive prosthesis. That's really important for your listeners as they continue to try to build their business and grow their business.
Oh, that's awesome. And there's a lot of empirical data in there and very objective. You also mentioned peer support, which may be a little bit more subjective, but it is absolutely an essential component of amputee recovery. Could you share the ways that you see that practitioners can help patients in their recovery journey?
I sure can. And this is where you get the head and heart. When I spoke about the head, the heart, and the residual limb, I just spoke about the residual limb when I talk about RRDs. That's all wonderful, but you have to have the mind of the amputee and the heart of the amputee in the game to get them back to return to as close as they can to their prior activities of daily living. In 2018, Kim Bartman, a nurse who runs the amputee program at the Lehigh Valley Medical Center, and I published in the Journal of Vascular Nursing an extensive review to identify the amount and the quality of the evidence on amputee peer support. Shockingly, when we dug up every single piece of evidence that was published and peer-reviewed, we discovered that there was not a lot of evidence, and that the evidence that was out there was not of a very good quality. There weren't randomized controlled trials. There weren't good matched controlled trials. Nevertheless, we made a practice recommendation that every single amputee should get peer support as a component of the healing process. So it begs the question, if you looked at all the evidence that didn't point you in that direction definitively, why would we make such a strong recommendation? And the answer is simple. When you look at evidence-based medicine, one of the things you look at is the risk of the benefit versus the risk, and the evidence that there's some harm to the maneuver. And what we found with peer support is that there was tremendous, as you mentioned, anecdotal evidence was overwhelming. And those are stories, and what people say that do research, they say a series of anecdotes is not a study, but it is compelling. And they found nobody that said peer support was bad, nobody that said peer support caused any damage, and there was zero evidence whatsoever of harm. And the possibility of benefit was just so great. And by the way, the stories came from amputees, from nurses that ran programs, from families of amputees, and from prosthetists that cared for the amputees. All had examples where peer support was a tremendous benefit.
Yeah, and it almost seems obvious, it's kind of like, why not? But when you really make it a significant point to mention it and recommend it, I bet you get a lot more of it going on. Is there ways that you can nudge people or guidelines to help them promote that type of peer support?
It's interesting you mention that. When I talk to surgeons who do amputations and discuss peer support, I've never had one say, "Oh, I don't want that." And so it's not really a big sale. It's not a difficult thing to do. The prosthetist can simply say, "I'm going to provide a peer support visit." And the surgeon will go, "Great." It's not like they have to write a prescription for it. It's not like they have to do anything out of the ordinary. And it's really in the hands of the prosthetist. Now, I will point out that some prosthetists that are also amputees will insist that they don't need peer support because they can provide the peer support. I would unequivocally say that's not really possible. That's a really imbalanced relationship of a caregiver and a patient. And what you really need is a peer-to-peer visit where there's not that imbalance in the relationship to be effective.
But even with today's modern technology, since like everyone's doing things FaceTime and things like that, it's so easy to do peer support now because it doesn't have to really be a face-to-face. You could do a FaceTime video or something like that. Have you found any evidence that that's been used at all and been beneficial?
The only report I read on that, Pierre, and it's a very good question. The only report I read on that examined that and said that it was just as beneficial to do a face-to-face as it was to do a video conference. And so it came to the same conclusion that you're pointing towards. It made no difference. And so for the convenience of the patient and for the peer visitor, a video call is just absolutely fine.
And who knows, maybe the amputee who's talking to the new amputee could be in the beach somewhere running around with his legs showing, look what you can get back to, this kind of life. So
Right, exactly. And the interesting thing with peer support is the patients will ask a peer supporter things that they will never tend to ask their prosthetist or their physician. A common question, as you can imagine, for a lot of very young amputees is, when can I get back on my motorcycle? And they're just not going to ask that for the doctor because they're afraid they'll get some judgment, or from the prosthetist even, they're afraid they'll get some judgment. Whereas the peer supporter will say, look, here's the way it is. You can get back on your motorcycle as soon as you feel comfortable to do it. And please know that the risk of losing your other leg is exactly the same as it was losing your first leg.
We see it all the time out in the field when we're doing trials and whatnot, and we call it, the prosthetist walk. You'll have patients, walk their best, but then as soon as they leave the door, maybe some of their normal lifestyle inadequacies come out. And it's if you don't do those everyday activities in the prosthetist's office, you're almost, kind of painting a picture that isn't so real of what your real life is. So I imagine these conversations are just the tip of the iceberg to opening up all this kind of resource and support that they may not be, willing to ask their prosthetist, right?
Right. Another great example. I mean, that's a great path to go down. Another great example is if they're having a problem with their socket, they might not tell their prosthetist because they're, nervous that they're criticizing their work. And they may tell the peer supporter, in which case the peer supporter can encourage them to go ahead and talk to their prosthetist about that issue.
This is all great about the peer support and everything, and it's vital to our industry, I think, to get more prosthetists to be using their amputees to help support the new amputees. But getting back to the patient falls, because unfortunately it's very common inpatient occurrence, as well as during the pre-prosthetic phase. You recently published this topic on amputee falls. What did you discover in that research?
Well, it's interesting. Dr. Krulin out of UC Davis, he's a orthopedic surgeon who does the majority of amputations at UC Davis. And I had published with him earlier on the RRD evidence. He was the senior author on that study. So I got together, after we were invited to do an article in Current Physical Medicine and Rehabilitation Reports, I got together with Dr. Krulin, did a review of inpatient falls among lower limb amputees, a review of the entire body of evidence. So we published that in 2023. And what we discovered was really alarming. It was just shocking. For perspective, before I discuss inpatient falls, it's important to remember two things. One is that the average hospital length of stay for an amputee is about 6 days. It's not long. It's only 6 days. The second thing to remember as I go into discussing what we've discovered is that the acute care setting is where the patient has the most intense observation. It's where they're least likely to fall, not most likely to fall. So all that said and done, with that in mind, in the acute care setting in the hospital, the research shows you, as published peer-reviewed research, shows that 16.5% to 20% of amputees experience a fall in the acute care setting during the 6 days. It's the highest fall rate of any subset of patients in the acute care hospital. Second is stroke. That shows it's not an uncommon occurrence. The second thing is 3 to 4.5% of all the transtibial amputees fall hard enough to go back for revision surgery, which, is a euphemism. It means they go back a week in that same week for a second amputation. And it's just tragic. And although it's old research and a very small study, there was one study done that showed that 47% of those that fell and had to go back for revision surgery were revised at a higher level. They lost their knee. And the average life expectancy for an above-knee amputee is 5.5 years in the United States. Additionally, not my research, but outside research shows that predicting who is going to fall is just an impossible thing to do. You can't do it in the amputee population. So if they're diabetic versus trauma patients, you can't figure it out. If they have a high BMI, low BMI, can't figure it out. Smoker, non-smoker, can't figure it out. Male, female, can't figure it out. So there's no way to determine who is going to fall, which is interesting. And then the other thing that research shows that the programs that hospitals put in place to prevent falls, which were all put in place after the hospital-acquired conditions regulations were put in place, and those were effective with, for instance, urinary catheters. The programs were not effective for preventing falls. So there's nothing you can really do. Ultimately, what you have to do is protect the residual limb from damage due to the falls.
Also with falls, I mean, I've had amputees that just bang their brand new amputations when they're transferring or something that did just as much damage, I think, as a fall.
Right. And by the way, those numbers go up as the patient moves from the most intense observation setting of an acute care hospital. The fall rate's higher. It's more like 33 to 40% in the rehab setting, inpatient and outpatient rehab. And then as they get into the community setting, there's a much higher rate of falls. There was a study done that shows that from amputation to ambulation, average patient amputee falls 60% of the time. 60% of the amputees experience a fall. So needless to say, that the issue is really we need to protect the residual from the falls.
And getting back to what you stated earlier about the IPOP, the soft one, and the rigid dressing, how many people are still using the IPOP?
Very low. So IPOP and hard cast is less than 1% of the market. It's very, very small, very select population.
And the hard cast, I know, like when I would see a patient, I would put some socks on his limb, like the thick, like a couple 5 plies, then put like a single ply on, then do a rigid cast over the distal end of the bulbous part with plaster, and then they could don it and take it off. Is that what you're considering a hard cast?
Yes.
Okay.
And the hard cast absolutely produced fantastic results. The only issue was it was not easy to inspect the surgical wound. It was not easy to don and off. So they'd have the hard cast on for 3 days, 4 days, 5 days. They cut it off and the wound's infected. They'd be like, what did we do here?
Okay, so yes, so like my hard cast, I would just kind of do a distal end cap that was on the sock, so they could easily take the sock off, inspect it, and put it back on. But just the distal end was hard cast. What would that be considered?
That's considered a hard cast. And that's actually what's referred to as the Wu dressing. Dr. Wu out of Northwestern invented this whole category of removable rigid dressings with exactly what you're describing. And he published in it in 1979, I believe. And so from 1979 until now, there's been this continually mounting positive evidence around removable rigid dressings, and it's still only 14% of the market. The criticism of the device that you just described, the Wu dressing, is it does not prevent knee flexion contractures.
No, it does not. But the biggest problem, I think, with RRDs are the reimbursement, and people don't get paid for them. To make that cast costs us maybe $4 or $5, and I'm protecting the patient's limb, and then I'm having a much better outcome with my prostheses down the road. Because hospitals typically don't pay for the RRDs.
Right. In the reimbursement area, that's a big criticism of RRDs, is they don't pay for them, and particularly if they're a Medicare patient. If they're a managed Medicare patient, they may be paid for. Or if they're private insurance, they may be paid for. But as we both know, the majority of amputees are for dysvascular disease, 82%, I believe it is, and the majority of those are Medicare. And so you're correct. The RRD oftentimes does not get paid. But I would encourage the prosthetist to look at it this way. It's a way to have the first opportunity to touch that patient and the first opportunity to build that relationship. And ultimately, more than often than not, they will then get the ability to service that patient with other definitive prosthetic device and have a lifelong patient.
Correct. And you're also setting yourself up and your patient for much better outcomes if especially if you're going back for revision if you fell and now you're an AK before you're a BK. You have a better outcome chance with a BK than an AK with some of these patients.
Of course.
Well, so, I mean, I think you've made it blatantly clear the necessity for RRDs, and we've heard the advantage of them over some of the other options. If I were a clinician, and Pierre, you are a clinician, let's say you didn't know about this, or, you're kind of dipping your toe in this water for the first time, where would I go about selecting the proper device for my patients?
I think patient selection is probably the easiest discussion point. The evidence clearly shows that all transtibial amputees would be better if they were fitted with an RRD. And we talked about all the many benefits of the RRD. So, I would suggest that clinicians select the specific RRD that they decide to use based on design, service, price, relationship, and support from the company that manufactures the device. There's no evidence to show that a custom device is any better than an off-the-shelf device. From a patient outcome perspective, it really doesn't matter which one is used, just so that an RRD is used. And when we did our landmark review on RRDs, that was really a mix of a bunch of different RRDs, including the WU device that Pierre mentioned, the FlowTech, the Limb Guard, the AmpuShield, all those devices and custom devices were all in those studies, all kind of lumped together. So the choice really becomes, do I put the patient in a RRD, or do I talk to the surgeon about using an RRD, or do I allow the patient to have an elastic bandage and a knee immobilizer?
Jim, thank you so much for joining us today. I mean, I can keep going on for hours with you, and I know we have to keep our podcast to a certain amount of time. So maybe at one of the state meetings or national meetings, we can get together and talk some more. But do you have anything else you would like to add to today's discussion?
I sure do. Yeah, thank you very much. And thanks again for having me. And I'll look for you at one of those meetings, and we'll get a chance to sit down and talk more about RRDs. It seems to me that, all said and done, that the optimal device would be a device that protects the residual limb, allow the hospital staff to apply it and bill for the device and not touch the surgical wound, because that's another criticism of RRDs. And surgeons will say, well, I don't want anything touching the surgical wound. And so that seems to me that would be the optimal device. But until the time that such a device is made, I would say clinicians ought to use the medical evidence in their discussion with surgeons and ask them to try it on just one patient that would be an optimal patient. The process is take care of that patient and then follow up with the surgeon and show pictures, show the outcomes of that patient, the shaping of the residual limb, and ultimately when the patient gets up in their definitive prosthesis, and working towards a post-operative protocol that would include an RRD in that surgical practice every single time, not just as a one-off here or there when the prosthetist convinces them. And that's really, from a listener standpoint, a great benefit of the RRD is it allows them, instead of going after the next patient, to go after the next physician practice and gather that physician's practice by becoming ingrained in their standard of care and optimal clinical guideline for their transtibial amputations.
That's awesome advice, Jim. Thank you so much for joining us today. And we really appreciate your previous dedication to your research and your ongoing research. So thank you very, very much.
Thank you, Brendan. Thank you, Pierre. Appreciate the time. And thank you very much for having me on your podcast.
To learn more about the research referenced in this interview or to connect with Jim on LinkedIn, please follow the links in our show notes. Thank you for listening to the O&P Check-in, an SPS podcast. We hope you enjoyed the episode, and if you did, be sure to leave a review and subscribe to the show on Spotify, Apple Podcast, or wherever you listen to your podcasts. Have a question or topic suggestion? Email us at spspodcast@spsco.com. See you next time.